Excellent. Excellent. Well, hi, everybody, and all of you hormonally inquisitive people. We are so glad that you are here. My name is Dr. Devaki Lindsay Berkson, but because Devaki is difficult to pronounce unless you're hormonally balanced, I go by Lindsay, Dr. Lindsay. Now, most who know me realize that my life, the way I like to say it, has been saved and ruined by hormones. But as much critical illness as I've battled by my mother being exposed to that extremely synthetic estrogen when she was pregnant to me, even in my late 70s with healthy, balanced hormones, this allows me to make good dents in a very hard world. So I have a fire in my belly to make sure that all of those who could benefit from HRT, which stands for hormone replacement therapy, are not denied it. So recently, our new FDA head, Marty Makary, has been doing great work to make hormones available to both men and women. And based on what he's saying, hormones are right up there with antibiotics. And I don't know what to say about vaccines because he mentioned vaccines, but he basically says hormone health is foundational for both men and women. And from young to old, everybody should get their hormones measured, just like you do with lipids and sugars. Everybody but old women. Old women just keep missing out. So we're going to be talking tonight about the timing hypothesis. It is a theory, and we want to talk about this theory. What it says is women are really benefited by hormones. Young women, if they initiate hormone replacement therapy in the perimenopause or 10 years out from menopause, and the definition of menopause is no period for a year. So young women that start hormones in the perimenopause or 10 years out from menopause, they're cool. They have a 40% decreased incidence of getting heart disease, which is how most of us exit this incarnation. And basically, it gives you 3 to 4 more health span years. Now, Dr. Makary is saying that men from young to old, even men with metastatic prostate cancer, are all candidates for testosterone replacement, but not old women. If you hadn't started hormones in the perimenopause, which is 10 years before you get menopause, it can be anywhere up to 10 years before you get menopause. And if you didn't start hormone replacement therapy from the average age of going into menopause is about 50, 51, so to 60 or 61, and you're 70, 75, you're out in the cold. You've missed what they call the hormone window. So I have this fire in my belly for you not to miss out. The timing hypothesis is really not set in stone. I called together my hormonal clan. Dr. Rosensweet was one of my physicians 33 years ago when I had breast cancer, and now we both have a fire in our belly about hormone health. Dr. David Rosensweet is an adopted brother of mine, and his daughters are incredible. They're going to be part of the new up-and-coming breast cancer symposium, of which don't go away, because at the end of this talk, we are launching for the very first time the available link with an early bird special for everything breast cancer, what's the science, and how to keep it safe. Holly Papanek is an incredible colleague. She dives deep into the literature. She's a clinician, but she's also becoming a dear friend. And I trust her very much, and I love her, even though she looks drop dead gorgeous. I do not have any of that jealousy bugging me. No, no, nay, nay, nay. So don't go away till the end of this evening because we're going to be launching everything breast cancer. But we're here as a group of concerned practitioners with together over 140 years of background of prescribing or of recommending hormones to patients. And we want to talk about our opinions about the hormone timing hypothesis. So older women aren't the only group left at all that misses out potentially on hormone replacement therapy. So David Brownstein, since you and I have such a long history and we've given everything hormones together, I would like you to start off our chat. It's a fireside chat. I don't know if you can see a little bit of my fire. There it is. You can hardly see it, but I have a little fire right over there. Give your opinion about the timing hypothesis of hormone therapy.
Thanks for having me, Lindsay. And it was remarked that I wasn't wearing a Michigan shirt today. And the reason I'm not wearing a Michigan shirt is it's 0 degrees outside right now, and this is my warmest sweatshirt. So Michigan will have to wait till the fall till they win another national championship. But the timing hypothesis, I think the timing hypothesis is um, with all due respect to, what's her name, Saltpeter, Dr.
Shelley
Saltpeter,
Saltpeter.
who
That
first
it's all
introduced
based
it.
on her original
I
research.
think it's nonsense. I think the only thing the timing hypothesis proves is that hormones are safe. Um, when you look at her original article and the the benefits of taking hormones before the age of 60, right around menopause, and the benefits showed up in 4% versus 2% of the control group, which means there's a 2% difference. So the best thing that study showed, and there was not enough people in there was only a couple of thousand people in that arm of the study. So little variations in people who develop problems can really change the statistics very quickly. But a 2% difference between the group means you can say there's a 2% benefit to taking the hormones before age 60, meaning you have to treat about 50 women to get one person to get the benefit. 49 out of 50 didn't get it. Now, I don't think those numbers are anything to write home about. I think the best the timing hypothesis can show is hormones are safe. They're safe for women around menopause and they're safe for women well past menopause. That's what I think about that whole thing.
I agree with you totally. So, Shelley Saltpeter first published the first study ever with the concept that when you initiate hormone therapy, what does this have to do with mortality from heart disease? Because women are more prone to recurrence of heart disease. Women don't handle, once they don't have estrogen in their body, heart disease very well. So it was a meta analysis. She had 30 studies in there. And none of the studies except one was looking at the role of HRT in mortality. So what she did was, oh, this is about hormone therapy and bone integrity, and this one is about hormone therapy in the lining of the uterus. So I think I'll give this one 10%
Right.
and this one 25%. It was massaged data. And what I didn't understand, and I sent to all you guys this afternoon, I know it wasn't enough time to talk about it, was when I went into the discussion section of her study, she said everyone on HRT, both in young and old groups, had decreased mortality.
I believe that she had that hypothesis in her head before she did that study and just, as you said, massage the numbers to come up with what she wanted to come up with. And there's not enough. Look, the study is good because it shows hormones are safe. And they're safe whether you take it at a young age or safe whether you take it at an old age. And I think that, a 2% difference is just, with a small number of people in the study is not much worth talking about. But what's worth talking about is how safe they are.
You're the king of the statistical ratio and so forth. But Holly, Dr. Papanek, I would love for you to talk about the issue that these are all old studies from the 1980s to 2002. So all of these studies were using estrogen and synthetic progestins, which we call the monster molecules. Can you talk about that, Dr. Papanek?
Sure, sure. And I think it really needs to be distinguished, and it's really changed my practice recently. When you look at primary prevention, right? This is the younger folks where we're preventing cardiovascular disease. So starting within that early window, right? Versus secondary prevention, which it has to be looked at differently. Those are women that have known cardiac disease. What happens with them when they're on hormones? And so that was some of the study, whether it be Salpeter's review, whether it be WHI. And you could almost even back this up in terms of these studies. It kind of happened even before salpeter. It was the WHI that came out 2002 when 85% of the hormones went down, right? It was because of the release of breast cancer and cardiovascular
But
disease.
almost all those women in that study were 10
I
years
know.
out. They were all in their mid
Absolutely.
60s and
Right.
overweight and smokers, right?
And hypertension,
Right.
exactly. Obese, what have you. So they were not healthy, you're right. And the average age was 63. So we're already kind of looking at that window. But what I've gained from that, or kind of how I look at my practice and my patients differently, is specifically the climacteric study of 2024. that is a fascinating study. It kind of opened my eyes to what do we do with these women? Because number one, it was kind of a meta-analysis. They looked over 5,000 studies. They chose 23 randomized control and 6 observational.
Is this the
And what they,
saltpeter you're talking about, or the
no, this is
climacteric?
climacteric. Yeah, it's a
Okay.
meta-analysis. Yeah.
Okay.
But what they found is women that had known coronary disease. So they'd had a previous MI, they'd had a stent, they'd had, bypass, what have you. There wasn't benefit, but there also wasn't harm. That's huge, right? Because we know that, okay, there may not be benefit. Maybe we've lost that window in terms of overall benefit, which I can dare say we can look at some of the benefits that estrogen and progesterone and such cover, but there is benefit. But again, there's also no harm. That's huge. Because if you look at a lot of the cardiovascular data, as soon as there's an MI, as soon as there's a vascular event, they pull them off anything. And in fact, there's not harm. There's a decreased risk of mortality on hormones if the woman comes in with an MI. So it really changed my whole
A
practice.
heart attack, for those
Yeah,
that don't know what
right.
that is.
Right. With not only the prevention, but also kind of the long term. Listen, there's no harm. And the women actually on hormones do better. So anyways, that's kind of the study that I tend to reflect upon.
What's
It's
the
just
name of
very,
that study? Do you know? Or
yeah,
would
well,
you put it in the chat so we can
I
share it?
can. Yep,
Okay,
it's by
great.
climacteric. Yep, I will.
It's published in Climacteric, but it's
Yep.
got a name, right?
Yeah, 2024, but yeah, I'll pull that into there. But
So, in looking, I was the keynote speaker for the Arizona Naturopathic Cardiology Convention a few weeks ago. And if someone gets on estrogen right after having a heart attack, it decreases the size of the damage. And it also helps protect their contractility to prevent them from getting AFib. And which is really, you don't want to get AFib when you get older. It's not a good path to go down. And if you're on hormones, you have less risk of getting AFib. So, Dr. Rosensweet, would you join us in on this discussion? What do you think about what we've just been chatting about?
Well, I think I'd like to begin with a statement that I feel is the summation of the medical literature.
Oh, I'm going to
And
like this.
and it is that we're all at risk for thousands of diagnoses and hundreds of cancers and cardiovascular disease. Given that we're all at risk, women, for example, who are on hormones are at less risk for breast cancer, heart attack, and stroke than women who are not being treated with hormones. So just sum up all the literature, that's what we could say about it. Another way to look at it is we know that estrogen's protective to the heart and to the coronary arteries. Like I used to hear very rarely that, God, the young man was 40 years old and he was in perfect health and he had a heart attack on the tennis court. And what we know in medicine is they don't hear this about young women. We've known for a long time that young women have special protection to their coronary arteries, and it's rendered primarily by estrogen. So the 10-year window, if it is true that a woman loses the vast majority of her estrogen in menopause, and she goes years and years and years without estrogen, she is going to be more vulnerable to coronary artery arteriosclerosis. And the way I like to look at it, though, because we have a different viewpoint here, patients come to us and we meet the 60-year-old woman who hasn't had hormones for 10 years. And all of a sudden, it becomes a very individual issue. And so we look at, oh, we know about she's lost protection to her coronary arteries, and we know something about that if we treat her with hormones, here's something really wild. For 1 year, if she has a clot in her coronary artery, and women with atherosclerosis can get a clot in their coronary artery, for 1 year, she's vulnerable if we bring in hormones, if we bring in estrogen, for that clot breaking loose and her having a heart attack. So clinically, when a 60-year-old woman comes in who hasn't had hormones for 10 years, we pause, we evaluate to see if she's got a clot. And if she doesn't have a clot, all systems go.
And isn't it by the second year? If the first year there was just a teeny bump in vulnerability, by the second year, her protection triples. And Shelley
Yeah.
Salpeter talked about that in the 2004 and 2006 articles. So I got a question, both you and Dr. Brownstein, when we were chatting about this among ourselves, you were saying when you both got into hormone therapy, you gave it to your elderly mother and mother-in-law and father that were really old outside of the timing hypothesis, and they did great. Do you want to comment on that? The two Davids?
David, you want to
Well,
start? Yeah.
my mother started hormones about age, trying to think the exact date. She was in her 60s, and I learned about it. And she's now 93. She's still on them. Um, she asked me maybe a year and a half ago, how long do I have to take these hormones for? You've had me on them for decades. I said, oh, Mom, I don't care if you don't, if they're not helping you, don't take them. And she goes, well, can I just stop them? I'm like, if you want to. She called me up 2 days later and said she's taking the hormones till she leaves the earth. She plays bridge with her friends. She said I couldn't make decisions on the cards, and um, her brain was foggy, and it took about a day off those hormones, and she's still taking them at 93 right now. And um, that's been my N of one, showing the benefits of hormones into the 10th, what is that, the eighth, like 10th decade of life. Um, and I've treated
I,
so many older people with hormones. I only see improvements. I've never seen anyone. Look, I've seen people have problems with hormones, young or old, but it's a whatever that can happen. But I have seen generally improvements. Never any serious problems with them at all. No matter when I started, I've started women in their 80s, men in their 80s on hormones. They've all done well.
So, Dr. Brownstein, how long have you been using hormones in practice?
I've been using hormones about 30 years.
Dr. Rosensweet, how long have you been using hormones in practice?
33 years.
Okay, Dr. Papanek, I love your name. It sounds like I'm singing. How many years have you been practicing using hormones in practice?
Probably about 10.
Okay, that's a lot of years of experience. Have you initiated hormone therapy in older women and it's gone well? Have you ever had a negative event, Dr. Papanek?
No, not at all. And most of my career I spent mitigating all the difficulties and the chronic diseases that occur from, dare I say, low hormones. So spent a great deal of my career in patient critical care, handling the MIs of the women that are not on it, the congestive heart failure, the AFib, the progression to dementia, the fractures and such that occur from just not having the hormones around. So I have completely flipped my practice, and I will be moving towards prevention for the remainder of my career. So absolutely.
Dr. Rosensweet, have you ever seen a problem in your older population with initiating hormone replacement therapy? And yes, I saw one of the questions. We are referring to bioidentical hormone replacement therapy. That's what we're all in consensus about.
I decided to treat my 86-year-old mother-in-law who had had three coronary operations for three bypasses on three different occasions. But the risk-benefit analysis was so much in favor of her not losing any more muscle so that she would fall and fracture. We gave her the hormones, and we have a video of her actually sitting on a low couch and being able to stand up with her arms up in the air, demonstrating that before she could not walk without a walker. The hormones are crucial, and I treated my 87-year-old mother, who I couldn't do the cardiac evaluation on. There was no way she was going to go to a cardiologist to do this, and I started treating her, and we have a video of her no longer needing to walk with her cane. These things, and I've had a big laugh with someone that we all know. He's a pharmacist in outside of Dallas who's been treating men and women since the 1980s. And when that study came out to scare everybody,
The Women's Health Initiative, you mean?
well, the one that the 10-year window and
Oh, the Salpeter
the
study. Okay.
yeah, we took a deep breath, and he thought, my God, I've treated so many elderly people with diabetes, with heart disease, with obesity, and never had an event. And I had never had an event. So there's this
And he just had his
propensity.
wife go through breast cancer and he kept her on hormone replacement therapy all during her treatment. She's doing great and still on hormones, right?
Yes.
Same with my mother. She she kept on her hormone replacement therapy after her diagnosis and treatment of breast cancer.
And of course, I had breast cancer 33 years ago and started hormone replacement therapy 30 years ago, which is one of the reasons we're here chatting besides the timing hypothesis. We want to make sure that women don't be denied of hormones that can help them have a higher quality of life and even prevent recurrences or fatality if they do get a recurrence. That's why we're here. We want to
So,
pass forward the good information. Sorry, what do you
so
want to say,
Lindsay,
David?
so you asked the three of us how long we've been doing it. That comes up to about 70 years. Why don't you add your numbers in and tell them how many years of experience are on this panel right now?
So 33 years.
So 100, over 100 years of experience here.
I think there's a theme in the medical literature and the medical world that emphasizes scaring people. And I think this is just another example of it. And what it really comes down to when individual patients show up, it's to pay attention to them and see where their vulnerabilities are and act accordingly. And the number of times when hormones are not called for, well, I haven't run into one. For all the patients in 33 years who came to me, I've never seen, oh, I don't think we should give you hormones.
So
Never.
you say the scare tactics are there. So why are the scare tactics there? Because if we don't give men hormones, they're grouchy, they're irritable, they're depressed. What are we going to give them? Same thing we'll give women who aren't sleeping, who are irritable, who are grouchy. We'll put them on antidepressants and a whole bunch of other pharmaceutical medications that, treat the symptoms of an illness, not the underlying cause of the illness. And that's why they're scaring everybody away from these natural therapies, and hormones are just one of them.
So do you believe that if we're hormones are foundational and if people aren't allowed to use them and after 40 they just start going downhill precipitously, that many of the medications that we then start being recommended for high blood pressure, for reflux disease, for heart disease, for high cholesterol, we wouldn't need as many meds? Do you feel that this fear generated against hormones is mainly driven by money and power? I
This
do.
is this is a known belief system among many who pay great attention to what in the heck is going on this planet and in the world of medicine as well.
And we look at the fear we all experienced during COVID to get that clot shot vaccine that we shouldn't even call it a vaccine, that gene altering therapy. And it's just, if that didn't waken everybody up to this is just another prime example of it.
And I have so many friends that listen to the mainstream news and they hear these conversations and they just are so bewildered and angry about it because they believe mainstream news, but mainstream news is mainly supported by big pharmas, the advertisers. Is that not true? So that's why Dr. Patrick Soon-Shiong went ahead and bought the LA Times. Once he figured out that we weren't getting all the straight news, he bought the news and he wanted to disseminate it more. Holly, do you have comments on this?
Well, I mean, it's definitely just a fear tactic, and we obviously can't patent things that occur naturally. So all of our bioidenticals that we use that match biochemically our individual hormones, they're just dismissed. They're rarely studied. They're often batched into studies as just progestins and such, and they're completely different. So it's difficult sometimes to tease apart that literature. But I mean, it just goes without saying that I do think the tide is turning. I mean, we've seen the black box being removed. I think women are pressuring physicians and big pharma and media, what have you, to say, we've had
But
enough.
older
Some of
women still, McCary was saying,
yeah,
because of the timing
yeah.
hypothesis, everyone else in our humanity, young women to middle-aged women and young men to old men, they all are candidates now for hormones, except older women. And that's why we wanted to have this conversation, because we don't think older women should miss out, because when you are replaced with your hormones, you have such a higher quality of life. I just turned 77. If I hadn't been on hormones all this time, I wouldn't be holding this conference and having this conversation. It's really, really true. And we're about 5, 6 minutes away from doing the Q&A. But I just wanted to go back again to the study that created all this stuff. Although it's really, if you go even further behind that, I think we're all in agreement it's about money and power. But Shelley Saltpeter first published in 2004 that she looked at these 30 studies and looked at them all together, which is called a meta-analysis, and basically said that young women, if initiated earlier on hormones, do better. And it is true, the earlier you start hormones, the more benefits you get. But it doesn't mean you still don't get benefits even if you start older. But in the body of her study, she said that mortality was decreased in young and old alike, but she didn't say that in the conclusion. The really smart statisticians got to read the body of the study. And then in 2004, she went ahead and did a little bit more analysis on these same studies and came up with that statistic that I would like you to talk about, David, where she said the first year in older women, there's a 40% increased risk of heart issues. The second year, it's like you're protected like crazy. But that first year is making everybody say older women. I don't want to just say old women. It sounds a little bit nasty, although I'm in that group, so I'm kind of being a little bit jazzy about it. But would you comment on the true statistics of that, of the 40%, 7%? Because that's what even Macari is being hung up on.
These are relative risk numbers. These are hazard ratios, relative risk numbers. They really have nothing to do with the individual patient in front of the four of us as as we are making a shared decision-making process whether hormones will benefit them or not. Um, you know, we have 100 years of experience here. We went around the room here and we all said we haven't seen problems with it. I have seen zero problems with it, and so the three of you. And this is the problem with relying on relative risk numbers, that it makes a poorly performing drug or therapy look much better than it actually is, or makes a hazardous therapy look worse than it is. The only thing that study shows is that hormones are safe, period. It doesn't really show, there's a little bit of benefit, but the benefit is so minuscule in a number of women that were in that study. I don't even think that's that valid. The most important thing I take apart from her study, there's no harm with these hormones, whether you're young or whether you're old. And to talk about the benefits, talk to the four of us in 100 years of experience, because I don't see my patients, heart disease is our number one killer. I don't see my female patients getting heart attack after heart attack. I see them aging gracefully into older age and feeling good with these things. And when they go on to things and when they've been low on them, they feel better. Their brain's better, their mood's better, their libido's better, everything improves. Their lifestyle.
God, they just came out with a new synthetic drug to boost women's libido instead of testosterone for older women, because the older women are told they can't get hormones. So, David, I wanted your opinion a little bit on that. What would you do if an older woman comes in? Are there some tests that you would, what would be the testing you would do to rule out that clot that you were talking about?
Well, you can listen a lot to their story. For one thing, you want to know if there is increased risk in their family, for example. Is there a mom who had a stroke and then someone else had a heart attack? And then if you've got an older woman who's walking every day and never has had chest pain, or she goes to the gym no less, which is more and more common these days, and she's on a treadmill and she's never had any kind of chest pain or shortness of breath, you got a real good chance that her coronaries are functioning fine and do not have a clot in them that would reduce circulation to the heart, that would make it very hard to push a treadmill. But if you wonder, wow, she is having trouble, she can't walk a block, she has chest pain when she walks, this would be an extreme example. You turn her over to a cardiologist who has some very sophisticated tests that can see whether there's a clot in the coronary artery, because this is what we're really talking about. Will that clot break loose in that first
Would
year?
you recommend it clearly, the new
that would be state of the art.
But also David Brownstein has in his office, he's got a non-ionizing radiation cardiac evaluation. And I don't know, what would be the three ways that all three of you would evaluate the cardiac status of an older woman that was wanting to go on hormones?
David brings up a good point. And look, we're treating the patient. If they're symptomatic, you're going to be a doctor. You're going to search for, is there a problem there? Let me ask the three of you, with our 100+ years of experience, has anyone run into a problem putting any woman of any age on hormones, and all of a sudden, we've got a cardiac emergency developing right afterwards? I haven't seen it.
Zero.
I just had my birthday dinner for my 77th birthday, and all my friends are like 10, 15 years younger than me because they're dancers and mahjong players. And a lot of my friends that are my age, it's kind of isolating, are on a different path. And at my birthday party, everyone was saying, okay, so look at how you look. So what's the story? How do you achieve that? So my Terry, my neighbor, who's a dancer, she dances, she works out, she's a mahjong player, she's got a great marriage, but she looks very different than I look. So she goes, how do you achieve that? And I said, having been on hormones for 30 years. So what is the likelihood of you testing a woman and the longevity of how long you would leave her on hormones? Dr. Papanek?
So I have a handful of 70, 80-year-old women that I've started hormones on. I know that per the literature, there may not be a great deal of cardiovascular benefit that may be afforded to them. However, we're still talking about vessels. And when Dr. Brownstein was discussing, their brain is better, their urogenital, their bones are better. Remember, those are vessels that are supplying all those things, right? Those are vessels supplying that brain so that the hormone can get to the brain and such. So the overall vascular health is marked, and it affects all of our organ systems, right? We know that estrogen largely can act like a calcium channel blocker. That'll lower your blood pressure. It decreases ACE inhibitors, or it decreases ACE, so decreases angiotensin. So there are market benefits that still go on, even if we're not going to get that increased pliability about the heart. There's still going to be vessel changes. There's increased nitric oxide. There's going to be, more plasticity and elasticity that still may be occurring with maybe some remodeling. So I don't hesitate anymore. And when you look at some of the data, I actually just attended a women's cardiovascular conference at Christ Hospital. Not Cleveland Clinic, the Mecca, right? But Christ, they're kind of the redheaded stepchild, but they're trying to get into this cardiac world, right? They talked about how women's hearts are built structurally different than men. We are not small men, per Stacy Sims, right? Our vessels are far smaller. We very infrequently have plaque obstructing or structural obstructions. Women are more commonly having microvascular ischemic events. They have all different terms now that they're looking at. INOCA, MINOCA, that has to do with, it's a microvascular ischemic event that has everything to do with that endothelium, right? And protecting that. So we need different treatments. We need different evaluations, but we know that hormones protect those things and they sustain them over the long haul. And I say we put women on hormones at whatever age. Again, it doesn't cause harm, and it may help per the literature. And we, in fact, know from experience, it does help.
Okay, oh, sorry about that. I didn't mean to cut you off. Did you want to finish that sentence?
No, just across many organ systems. Okay. We need that flow.
Thank you so much. I'm just going to start going to the questions because there's a lot of questions. In fact, I just saw that Dr. Zan Simonson, who is the president of the Arizona Naturopathic Board and one of the people that I adore. If I lived in Arizona, she would be my doctor. Let's see, where is that? Why am I not seeing that? Where is that? I had it up here before. Where's that page? Okay, I'm going to have to go get that again in the, I guess in the chat.
I'll drop it to you in a private
I had
chat.
it, but I just don't see it right now. I don't know why I don't see it. Thanks. Were you going to drop it in the chat? Sarah, are you dropping it in the chat?
I will.
Okay.
I will.
Okay, thank
just
you.
1 minute.
It's just all your questions. So they put them in a document and we want to get to them. Unless any of you guys want to say something while I am searching for this document. Where is it? Okay. I'm just going to start up here while you're looking for that.
How long should women be on hormones? How long should men be on hormones? When someone cannot get the lid off anymore. That would be the last day of breath. That would be my recommendation.
So one of the very first questions, and I love that answer, David, is does bioidentical hormone replacement protect women from Alzheimer's disease?
This is one of the most significant changes that I see that is so treasured by women who so commonly get some form of cognitive decline that can be so disruptive, even in midlife. There's a lot of different causes of Alzheimer's, there's a lot of different causes of dementia, but it's just amazing how much relief and recovery there is that women have as you institute a bioidentical hormone replenishment program with her. It's one of the most dramatic and it's one of the most rewarding to see the brain come back. And it's one of the scariest to see the brain disappear. But to see it come back when you treat a woman with hormones, and usually in a very short period of time, it's one of the wonders of the work that we do.
So
And
Dale,
I'd
I'm
venture
sorry.
to say that all of us have had that same experience because I have. I know
Will you repeat what that experience is, David?
that in women and men, when you get their hormones rebalanced, their foggy brain comes back online, their difficulty recalling things comes back online. We've all had I'm sure you've had the same experience I have, people coming in tearfully saying, I thought I was losing it, or, you saved my life. A man with testosterone, a woman with estrogen, progesterone, plus or minus testosterone. We hear the same things.
Dale Bredesen is the neurologist from UCLA that's been training doctors and published in peer review, reversing mild and moderate Alzheimer's within 6 months, but not if you're at the end pathological state of the disease. And the very first thing he does in this litany, and he's got a book out called Reversing Alzheimer's Disease, and I interviewed him on my podcast, is initiate hormones, including thyroid, not just the sex steroid hormones, but looking at all of the hormones. So the next question is, doesn't the belief come from the fact that estrogen maintains arteries flexibility? Hence, when coronary vascular disease is present, the risk of ruptured clots becomes higher in the presence of estrogen. Anyone want to tackle that?
I don't think it really needs tackling. I think it's the same thing we talked about before. 110 years of experience here. How many of us have seen that happen? I've seen zero. I know you guys all agreed with me. It's a theory. The theory doesn't seem to play out in practice.
And I've heard this as well, varying themes, variations on the theme of what's actually happening when you institute estrogen. But again, where did this come from? Why did this become an alarm? Why has this come to the surface as being something we're really considering? When, as David's pointing out,
You mean that
this is extreme.
estrogen's dangerous? Is that what you mean?
Yes, and that estrogen can cause a clot to break loose and
Well,
cause a heart attack. Why? There's a shark attacks. What is your risk of shark attacks? Is it about the same as this clot breaking loose? Again, I point to the rising up of these tides of fear to scare people away from some of the biggest gifts we've been given. In all of medicine, I've never encountered a gift for patients than the replenishing of hormones. Where does all this fear come from? Yes, we have to be careful. Yes,
It's
we have to
mainly
do.
money. It's mainly money from big pharma wanting their synthetic versions to be sold.
That's certainly a prominent theory.
Holly, were you trying to say something?
Well, it's just, there are several theories that we hear a lot about how, there's vasodilation, right? So that must rupture that fibrous cap that occurs. Well, interestingly, though, if you look at estrogen and progesterone, they stabilize the fibrous
They
cap.
stabilize that
That's
fibrous
right.
cap,
Well,
right?
I don't think that
The
theory holds.
metalloproteinases,
That's
right.
A whole lot of water. Another one you hear is that estrogen influences inflammation in the existing plaque. Well, Dr. Dash in his book spoke specifically about that.
Wonderful Dash, yeah.
Yeah, and they did a cross section of carotids, right? Comparable, right, to the coronary. And they actually found that women on HRT had less inflammatory cells within there, less macrophages, less monocytes. And we know that estrogen and progesterone, they kind of stabilize those adhesion molecules, and they don't bring a whole lot of those inflammatory markers to any ruptured endothelium. So I don't think we can say that our estrogen causes increased inflammation. In fact, it does the opposite, right? We talked earlier, decreases the inflammatory cytokines, decreases the cells that come to that area of inflammation within the endothelial wall. I've also heard people say, it's excessive platelet clumping. Well, that's interesting because estrogen increases prostacyclin, which deactivates, a lot of that platelet activation. So I don't know if that's it. One thing that Dr. Dash threw out, I'd never heard this before, so you please weigh in. He thinks it has a lot more to do with hormone deficiencies within the gut that result in a leaky gut, which then result in particles going across the wall, and we almost wind up with a low-grade endotoxemia with gram-negative
which a lot
bacteria.
of gunk in the inside of the gut
Right.
crosses the
Arterial
wall of
wall.
the gut and gets into the bloodstream,
right.
and you don't want that to happen.
Right.
And that's because the gut opens and closes with these sticky adhesive proteins, and progesterone and estrogen are what upregulate these adhesive
That's
proteins. It's the number one way we keep that safe. But Carlos, you're on here now with a question, and I've been trying to reach you because I've been trying to email you, and you sent me your email, and for some reason I don't have it anymore. But I'm going to read. It's a little bit long of a question, Carlos, but boy, I want to get in touch with you. Carlos Reynes is a very great thinking medical doctor. We have grand rounds on Wednesday afternoon that David Rosensweet has orchestrated. They're incredible with people who are really living in the weeds and trying to help you help your hormones and keep all of our hormones safe. And Carlos is one of the brilliant doctors on there, but he's talking after menopause, declining estrogens trigger several changes that push the heart toward concentric remodeling. That's if you're not on hormone therapy. Thicker walls, smaller chambers, so you really can't get that breath like you would want to do that. And basically, hormones help prevent the aging that normally takes place in the vessels that you would have if you age, but you actually slow down the Mack truck of aging on hormone replacement. But they're now saying everybody can do that except older women who miss that window, and we're saying that theory doesn't hold water. Here's the next question. Should older men be on natural estrogen in addition to testosterone?
So men get benefit from estrogen too. And the way men can get benefit from estrogen is take more testosterone. And there's an enzyme that converts testosterone into estradiol. And by optimizing a man's testosterone level, their estrogen levels will often optimize.
Okay. It's interesting. Both men and women need hormones. Why would Mother Nature make the very hormones that rule evolution and humanity be pro-carcinogenic? I've been pondering this for years, and when I had the honor of lecturing with Dr. Abraham Markenthaler at the Trump Hotel, the Doral Trump Hotel in Florida, he opened up with saying that very statement. He looked at the audience and he said, why would Mother Nature make the very hormones that drive humanity be cancer causing? It just makes no sense. And we need them all. So men need estrogen as well as testosterone, and a nuanced doctor that's trained by the menopause method led by the incredible, brilliant Dr. Rosensweet, or Everything Hormones by the work that David and I did together, or the BHRT Academy, like really quality hormone programs where you learn the nuances, because you can't ask your regular doctor who hasn't been trained in the nuances, because they will be more driven by fear, because it's human to be down on what you're not up on. So somebody says, what blood levels are you looking for?
Tricky to measure blood levels in people who are on hormones. They're based on when are you drawing the blood in comparison to when did you apply your last topical dose, for example. So you can come up with all kinds of answers around blood levels. I would put it a different way. I say titrate men and women to symptom relief and great satisfaction and pleasure, and then check their hormone levels to make sure that they're not overdosed or too underdosed at that point. And I'm going to stand firmly behind the only way that you can really do that when you're treating a woman or a man is with the 24-hour urine hormone test because of pharmacokinetics. When
But
did you
there's
draw
some
the
things you
blood?
can test in blood. David, do you want to talk about FSH, or do you want me
Yes,
to
great.
talk about
Um,
FSH? You can do it.
so Lindsay and I and David, we've talked about this on and off for years, and I've used
We've all
blood
been
levels.
friends for years.
I've used blood levels. I've used serum levels. Used urinary levels. I've used 24-hour levels. I think, David, you said it perfectly. Treat the patient. And I do think there's benefit to drawing levels, whatever you find reasonable, whatever you find most clinically correlates. For 3 decades, I've told patients, get your hormones checked in the morning. Don't take the hormones that morning. They take them the day before, just as they normally would. I don't really want to see peak levels. I just want to see either baseline levels or trough levels, whatever I'm measuring with that. And I've come to the conclusion I find accurate levels. I find it clinically accurate levels that I can adjust and correlate with the patient's symptoms, and it works for me. My partner, Dr. Ng, who's got as much experience as I have, he likes him to take it in the morning and adjust the hormones based on that. He doesn't have unhappy patients. He's got happy patients as well, and it works for him. So I think that the most important thing is look at the patient, and the levels can be secondary to that.
And I just want to add something about a few things you need to measure in blood. So estrogen and testosterone get into an Uber and drive around the bloodstream in an Uber. And if there's too many Ubers, the doors lock and they can't get out. And the Ubers are binding proteins. So you got to know the level of the binding proteins. If there's too many Ubers in the patient's body, they can't use whatever level of estrogen and testosterone they have. So whether you're doing whatever testing you're doing, you got to run sex hormone binding globulin. The same way with thyroid, the same way with all the hormones. They all have binding proteins that are the Ubers because hormones are fat soluble and blood is water soluble. So they got to get into an Uber that's water soluble, and kind of like the duck trucks here in Austin that can be a truck and then they get in the water and it can be a duck. But the big thing for me, I learned when I had Anna DeRosa on my podcast about 10 years ago, that part of anti-aging is not only bringing your sex steroid hormones up to a more youthful level, because as we age, they go down, but you also want your follicle stimulating hormone, which goes up as you age and causes all the same issues of aging: thin bones, brain fog, hard to lose weight, irritability. It causes all of that. And when you bring FSH in both men and women down to a more youthful level, the numbers get to a youthful level, that's much better. And you have to look at reference ranges of a 25 and 30-year-old. You can't ask your regular well-intentioned doctor to run labs and he'll tell you you're totally fine. Well, you're totally fine for a 70-year-old, but you want to feel like you did when you were 30 years old. I mean, I'm still kayaking 4 to 10 miles a week, and I'm 3 years from 80. So, and part of that's because my FSH is at the level of a younger woman. So I just wanted to mention
What
that.
number do you like, Debunking? What number do you like for FSH in women?
So for women, the FSH should be 25 or less, and I usually keep mine at 14. You don't want it to go below 5 because FSH still has something to do with mitochondrial protection. If it goes way too low, that's not good. But I have a patient who's a hormone doc, and she sees me as her hormone doc. And she opened up a clinic in close to 80, a second clinic, close to 80 years old, and she was keeping her FSH at 5 and doing just fabulous. So a lower FSH at the level of a 25-year-old or a 30-year-old, that's what you want to do, is bring your physiology back to where it was when you were younger. Of course, there's lots of things to do it, and anti-aging is the big buzzword, but FSH gives you a little bit of a readout of whether you're pulling it off or not. Like someone will come in and say, I've been on hormones for 2, 3 years and I don't feel any different and I'm pissed off about it. It's a lot of waste of money and I don't want to do it anymore. So we run their FSH and it's like 155. I mean, they haven't moved the needle. They haven't moved the needle. And testosterone lowers FSH in men and estrogen lowers FSH in women. Do you want to make any comment on that, Holly?
No, I wholeheartedly agree. I also see some increased inflammation with elevated FSH, some weight gain and such too. So there's definitely a lot of confounding factors within that. But no, I wholeheartedly agree.
If you want to learn more about FSH, I wrote an article in the Townsend newsletter called Fat Cells Can't Live With Them or Without Them. You can put in Fat Cells Berkson Townsend. It'll pop right up, and there's a whole section on FSH, and it's available for free online or at my website, Dr. Lindsay Berkson, online for free. Next question: men need progesterone and testosterone, but not estrogen.
I wouldn't say that.
I don't know.
I wouldn't say that. I would say men do need estrogen, and it's it's the story of the tennis court. Who is that young man at 40 years old who keeled over from a heart attack, never sick a day in his life? There's a belief amongst mentors in testosterone that these are the guys who have very low estrogen, And as David said, the ticket to raise any man's estrogen is raise their testosterone. In fact, one of the things we have to be a little careful of is not go too high with the estrogen when we're treating a man with testosterone. It's one of the bumpers that we have. We watch that estrogen level. You will increase your estrogen if you get adequate testosterone.
Somebody just had you have a whole complete explosion behind you with that. So we had concurrence from the audience. Thank you. I don't know who that was, but that was really well done. Any benefit of taking dehydroepiandrosterone or DHEA and pregnenolone?
Absolutely, there's benefit of that. These are adrenal hormones. They're produced in huge amounts throughout life. The highest concentration of pregnenolone past the age of 50 is in the brain. Um, I Pregnenolone helps brain function, like estrogen helps women with brain function, and testosterone helps men with brain function. They're all synergistic with one another. DHEA, huge amounts of DHEA are produced. I put women and men on both pregnenolone and DHEA. It's one of the most common things I prescribe on people, and should be part of anyone's hormonal milieu.
So hormones work together as a family, and then they dysfunction together as a dysfunctional family. So a really savvy doctor looks at all your hormones, your insulin after you eat, your DHEA, your pregnenolone, et cetera, the whole family of hormones. That's really important to do. And Dr. Lebray was the famous French scientist who said that DHEA keeps estrogen acting as good as she could possibly be. And he wrote extensive articles about how DHEA oversees and caretakes healthy action. So all the hormones influence each other. They're not just testing estrogen or testosterone. They're a huge family and they work together. And if one of the family members is sick or ill or low or too high, they're not going to function well. And a doctor that's trained by the menopause method, by everything hormones, by BHRT, by really the great provider takes all the courses and listens to the people that have been making this their life study. That's who you want to go to for providers. So if someone wanted to go to providers for the menopause method, what would be the website there, David?
They should contact,
I've dropped it in the
bright.live.
chat, Dr. Rosensweet.
Okay.
Katie sent it to me and I dropped it in the chat.
Okay, great.
And I'll put it in again. So it's
Thank
there.
you.
And we have everything hormones on my website, drlindseyberkson.com. And I'm going to twist Dr. Brownstein's arm and see if he'll be okay about putting it on his website. I don't know. I'm just saying this. He hasn't heard me say that. But Carl's, is testing routinely done when on HRT for longer periods of time? If so, blood or Dutch urine? Oh, I know you want to mention something about Dutch urine, Dr. Rosensweet.
Well, I'm not a fan of dried urine testing, and there's several places where it breaks down for me as we look at it scientifically, including the gap between when the urine that registers the hormones that were applied, pharmacokinetics again, extracting it from dried paper. I have a lot, and we did split testing, and although certain testing correlated, the dried paper did not, and the 5-point did not. So I'm very concerned about the science that's involved in it, and yet the marketing is some of the most fabulous marketing that's ever been done in the medical field.
So the next question is, so HRT does not prevent breast cancer? Yes, it does. The largest study ever published, although there's pros and cons with it, which was women over 65 and the routes and doses of hormones. It was called the 10 million study by our NIH. They looked at 1,500,000 women on hormones versus the rest of the 10 million women that weren't. And one of the biggest things that came out of that huge study that was published in Menopause in April in 2025 is that women on estrogen have statistically less breast cancer, less lung cancer, and less colorectal cancer. And every form of estrogen, whether it was conjugated equine estrogen from Premarin or whether it was bioidentical estrogen, all protected breasts and all the reanalysis of the Women's Health Initiative. Estrogen protects breasts. Why wouldn't Mother Nature make estrogen protecting breasts? Why would she make it a hormone that didn't like breasts? It doesn't make any sense. But somehow we've gotten into this fear over hormones, which we think comes a bit from money. Also have some Okay, we just said, what about breast cancer? We just said that. Would love your thoughts on tibolone. Well, that's a very powerful synthetic progestin. And in fact, that in the Stockholm study, they eventually came out and said, the real issue was tibolone was so breast unfriendly. It's a synthetic progestin. Anyone want to comment on tibolone?
Yeah, the Swedish study that came out, it was a million women Swedish study. They looked at 8
Oh, right.
varieties of different types of hormones, which I love very much. So they had the transdermals and such in there, but tibolone was in there. It did not fare well. Increased risks of cardiovascular disease, ischemic heart disease, increased risk of clots. So it didn't fare well. It's another progestin. I would just avoid them. And I want to answer that next question. How do we get by the first?
Okay, I just want to say one thing. I was having a cup of coffee at Starbucks, and there was this woman from Belgium, and she goes, "Oh, you're into hormones. You're into hormones. Let me tell you the hormone I'm taking, and I want your comment on it." She brings out tibolone, and I go, oy vey, not non bueno, non bueno. Okay, go ahead and do the next question.
Yeah, the next one. How do we get by the first year late start risk issue? Don't use synthetic hormones. That's easy.
That's the bottom line.
Yeah, it's the bottom line. It really is. There's really not a whole lot more to say. And we know the bioidenticals are protective and they continue on with extensive benefit across multi-organ systems.
So Dr. Rosensweet and Dr. Brownstein, would you agree with that, David?
I would agree 100%. And as far as tibolone goes, any progestin should be avoided. That includes progestins in birth control pills, progestins in birth control shots. These are dangerous substances.
Depo-Provera. Can you want to talk for a second on Depo-Provera?
Oy vey. Talk about tibolone. Depo-Provera's got a beat. Depo-Provera is the worst thing, and it's still given out there. It's just a disaster, and it should be pulled from the market. And I hope before these 4 years are up, the Secretary of HHS gets on this one and takes it away from the market like it should have never been put on the market.
When I wrote Safe Hormones, Smart Women, there were about 100 papers that looked at the level of the natural progesterone in the bloodstream of the woman going in for breast cancer surgery. And then they tracked them for 20, 30 years to see if women with higher levels of progesterone, because that's also an anti-cancer hormone, if they did better. And women with high luteal phase, that's when we make most of our bump in progesterone. Those women lived longer. If they did get cancer, they had less aggressive kind, and they fared better. But in 2011, an Indian group came out and said, hey, if progesterone helps protect against cancer, everyone going for breast cancer surgery should get a Depo-Provera shot. And after that, the rest of those studies started disappearing away from PubMed crazily. And Depo-Provera, which David, you were sharing with me about the label that it says you lose bone on this progestin, and we don't see that you can really ever gain 100% of that bone back.
You can have irreversible osteoporosis with one dose of Depo-Provera.
With one dose, we are being really smokescreened. We are being made to be fearful of our own hormones, and we are being sold a bunch of synthetic hormones. And that's why they could all be resting. They've been seeing patients all day. I've been working on everything breast cancer and getting over a little bit of bronchitis. My voice is a little bit, we could all be putting our feet up, but we wanted to be here and have a community fireside chat. You kind of see my fire over there, and really share this because we have had the wool pulled over our eyes. Let's see.
I might add that these are the most powerful biochemicals in our body, and they behave intricately, specifically, in very, very high-tech ways. And why in the world would you want to take something that's a different molecule that was produced because a drug company could not make big money off of a molecule that's in our body? They can't patent a natural progesterone, so they can't make big markups on it. So what did they do? They created these molecules that are different, that they can patent, but they behave differently and they behave ugly, as you've heard here. And the Riot Act can be read on these progestins that they very conveniently make sound like progesterone, and they confuse it all the time. But here's the thing to do. Go for compounded bioidentical hormones. Compounded bioidentical hormones. I'm not mentioning other forms of what they call bioidentical hormones. I'm saying go to compounded bioidentical hormones. There's the same molecule that your ovary or your testicles produced.
It's really something. They have succeeded in making us scared to death of our own hormones. It's almost like convincing us the world is flat. So we have a few more questions. So if an 85-year-old is metabolically healthy, she can indeed start BHRT. Would you all agree?
If an 85-year-old is metabolically unhealthy, like my mother was, and my mother-in-law, who was severely unhealthy, they can receive benefit, significant benefit
And how do you
from
start
starting hormones.
HRT in older women with bioidentical estrogen? Is it creams, patches, pills, what?
You go lower and slower. You're very kind to them. You don't give them a gush of hormones. You start gentle and you gradually increase. My favorite is topical estrogen, topical progesterone, topical testosterone, DHEA in an organic oil base. And there's many forms of topicals out there.
David, you give mostly topical right on the skin?
Yes, I give topical and mostly, and I find that works well. There was a question that came through my daughter Jessie, Dr. Jessie sent me. David, you can answer this with me. It says both Brownstein and Rosensweet had mothers on hormones and they still got cancer. 1 in 7 women, you have a lifetime risk of breast cancer for women, 1 in 7. If men live old enough, there's almost 100% chance they're going to get prostate cancer. I don't think the hormones I had my mother on caused her breast cancer. I kept her on them afterwards. She's still alive 20 years later. David, I'll let you take it from there.
But
My
you know,
mother
if
and
you're
my
on,
mother, my
oh,
mother and
sorry, just
mother-in-law did not have breast cancer.
so I think if you're on hormones and you get breast cancer, you're in a better place. You have a risk of having a less aggressive cancer and of dying from it less and having it more estrogen receptor positive and PR positive, which give you a better outcome. And those early cases, the lawyers really got doctors sued when it was the opposite. They should have given them a gold star because putting them on hormones gave them a better outcome with their cancer. Now, I wasn't on hormones because I was so young when I had breast cancer. But one of the reasons we're giving everything breast cancer, which we're going to go to soon, we're going to go to a few more questions and then we're going to launch everything breast cancer. And you ought to really see our brand new link and how beautiful it all is. But I had breast cancer 33 years ago, of which David Rosensweet was one of my doctors at that time. So we go way back. And nobody would ever tell me I should be on hormones. Even my functional friends told me I was crazy. But when I was reading the literature, I couldn't find the science that really proved that. There's no study that shows that women taking estrogen, if they have breast cancer, do worse. And in fact, there's 25 studies where women who have ER positive, PR positive, mild and moderate cases were put on estrogen with matched cohorts of similar tumor size and similar age who weren't put on estrogen. And they tracked them anywhere from a few years to 36 years. And in none of those studies did women do worse. They only did better.
Same thing with men
So,
with prostate cancer and testosterone.
yes.
I can tell you without a doubt, the men who get the most aggressive prostate cancer have the lowest testosterone levels.
Boy, that is an important point. You want to say that one more time?
I've seen that over and over. My partners have seen it. Between me and my partners, we have about 100 years of experience as well. And the men with the most aggressive prostate cancer always have the lowest testosterone levels. That's been our experience.
And
And this has
that's
been
because why would
documented
Mother Nature make hormones cause cancer? It makes no sense. I'm sorry, David. What were you going to say?
this has been documented and written by a genius in the world of men's medicine. And yeah, it's just exactly what David said. The men who do have really aggressive prostate cancers have the lowest testosterone.
You know,
Hormones don't cause cancer. That's the thing. Cancer has causes. Cancer does occur. It has a myriad of causes, but hormones are not part of the cause. They're part of the natural health that helps us not get these significant diagnoses.
Abraham Morgenthaler says that for many, many years, everyone's thought that testosterone is like pouring gasoline on a fire and making prostate cancer blazing worse for the male patient, when it was only based on one study of Huggins so many years ago. And
One man,
one
One
man,
patient.
one
One
man.
patient.
one patient.
So a lot of what's in peer review, a lot of what you hear from your well-intentioned doc, a lot of even the saltpeter study that says that there's this timing hypothesis. If you read the belly of her study, it says that nobody that was on hormones had increased mortality, premature mortality, dying earlier from any cause. The problem is there's so much BS. David, you and I talk about this a lot. I mean, there's just so much BS in the world, and it's also in medicine, and we think it doesn't seep into medicine, but it does.
Well, the BS was never deeper than during COVID. And if that
Yeah,
doesn't make you question everything, I don't know what will. But
that's well said.
Criminal,
Okay.
criminal.
So I think we're going to have to, so Sarah, Karen, should I take a few more questions or should we put up the link?
Why
What
don't
do
you
you,
do a couple more questions and I'll put the information in the chat, but that lets you guys get a couple more questions in and then people can read the chat for the information about it.
There's a
Okay.
question that's come up here I'd like to answer. Is what about testosterone and heart disease? Would that be okay, Debbie?
Sure, take any question you
Yeah,
want.
that was an erroneous belief, but it's been totally debunked by a wonderful study called the Travers study, in which it's shown that testosterone has a reduced incidence of heart disease.
Definitely, definitely. You know, the FDA mandated that study to be done. And it's the same way with women. I remember I lecture quite a bit. You've all lectured for A4. Most of you have lectured for A4M. And there were people who would teach that you shouldn't give testosterone to a woman, that it would cause plaque and worsen heart disease. And I remember going outside into another room and calling each of the Davids up and going, "You're not going to believe what this expert just said." And so know that you can hear a lot of things about hormones that aren't accurate, which is, of course, everyone thinks they're accurate. We think we're somewhat accurate, but we spend all of our life reading the literature, and we wanted to have this fireside chat so you could at least, in a respectful manner, hear our opinion and make the decisions that are best for you. A few more questions that we're going to go on. I guess I'm curious about how do you determine who would benefit for hormones? I would say there's almost nobody who wouldn't. Because when you age, you have less hormones. When you add them into your body, you slow down aging. So who would not benefit from hormones? Anyone want to say who might not benefit from hormones?
Well, and I think it's never too late. I mean, even if we're not going to get that great cardiovascular benefit, again, we're not hurting. The outcomes are overall better. I would say quality of life is better perfusion to the brain. But let's talk about urogenital. Let's talk about, genitourinary syndrome of menopause. The most common hospital
Everything Southerly.
Yes, Southerly. Thank you. Number one hospital admission is sepsis, UTIs. That's number one for women. Well, those could be prevented, right? You restore that vaginal, that urogenital microbiome and the pH and the flora. That's a big deal, right? And these are not just sex steroids, sex hormones, right? These have beneficial effects on most of the functions we have in our body. And if you can prevent UTIs, prevent
Hey, Holly, how
hospitalizations.
about preventing nursing homes? And would you talk about that?
Well, sure. I mean, okay, let's talk about urogenital, and incontinence and interstitial cystitis and pain. And again, the infections, number one, right? But what about bones? What about fractures? What about the muscle loss that occurs? The sarcopenia or kind of that wasting that occurs as we get older and we don't have our hormones. So it's just one thing after the next. So there's never too old. There's always benefit that can be gained.
I love that. And then somebody else said the individual patients you see have a range of different lifestyles, behaviors, diets, BMI that have to be considered. So I want to just say one thing. Everybody gets to choose. I love being an American because we live in a country where we can still choose. Well, I want to have regular care. I don't want to be on hormones. I do want to be on hormones. I want to see a functional doc. That is a gift because I treat patients in Saudi Arabia and around the world. They don't have those choices. But I hear a lot from patients who are still worried about hormones. If nature meant for me to have them, I would have been given them by nature. So I'm just going to age gracefully. And a lot of aging gracefully is really maintaining the volume of your hippocampus, which is kind of where your sense of self and your memories live. So Yale wanted to know if you meditated and were mindful, and if you exercised a lot, could you maintain the volume of your hippocampus? Because after age 40, when your hormones go down a ski slope, you lose 1% on average of your hippocampus every year, which leads to aging and fragility. And then, of course, if that goes at a faster rate, it leads to diseases like Alzheimer's disease. So they had a large group of elderly people who were somewhat frail, and they had them meditate for so many hours a week, and they had them exercise for, I think, 3.5 hours a week, and they did functional MRIs and measured their hippocampus, because let's see, shouldn't aging and a good lifestyle and good genetics be able to slow down aging? Nope, none of it, no meditation, no exercise, nothing slowed down aging. But hormones, work from McGill University, can take a shrunken hippocampus, as long as it hasn't gone too far, and in 6 to 8 weeks start to revolumize it like a younger hippocampus. Like your liver, there's the two parts of your body that can regroup themselves. It's extraordinary, but mainly with hormones. Why would you not want to be on hormones? And I think we'll take one. Anyone see another question you want to answer before we go to the wrap up? And are you guys all enjoying this? Are you happy that you came tonight? We have almost 200 people on with us. Yeah, we're getting all kinds of fun little things. Is there any question? I have a 90-year-old female on BHRT. This is Dr. Zan. Hi, Dr. Zan, whom I deeply respect and actually kind of love. She's a good girlfriend. I have a 92-year-old female on BHRT and hormones optimized, and she walks circles around most of my female patients. She exercises 3 times a week, walks a mile a day, teaches art still to young children, and paints beautiful pictures. I have no problem putting women on BHRT who are older. So don't let anyone tell you that the hormone timing hypothesis should wrap you up in a rope trick where you can't move and there's no way out because this is set in stone. It's not set in stone. It was a theory with a lot of holes in it, and that's why we had this fireside chat tonight. Are there any final questions that anyone sees on there that you're just dying to answer? And if not, I'll go to the closing so we don't keep people up too much. Yes, will they add protection for cervical cancer from the HPV virus? That's a good question. Anyone want to tackle that?
Well, does the HPV virus cause cervical cancer? That's another question to ask, but that's for probably a different topic.
Do you think it does, David?
50% of cervical cancers have no signs of HPV in them, so they certainly doesn't cause all cervical cancers.
What about the 16 and 18 and the high risk HPV?
Peter Duisberg would say those are non-clinical old infection. I don't know if you can call them an infection, old signs in the cancer causing no problems with the cancer. Peter Duisberg was a brilliant PhD. He just died recently, and he presented a lot of data that HPV was not the cause of cervical cancer. And none of our fancy PCR techniques can find HPV in approximately 50% of cervical cancers.
What do you think about this Gardasil HPV vaccine?
Another oy vey. Too much aluminum, too many problems. Oy, oy, oy. We did just fine with cervical cancer with Pap smears and treating women. That was we might complain about conventional medicine a lot, but Pap smears were a good thing from conventional medicine. They markedly decreased cervical cancers, and I think we were doing fine with that. This HPV vaccine.
So what do you all think about them saying that when you're 65, you don't need to get yearly Pap smears anymore? I think it's because they don't want to pay for it, because it's an expense. Because I think every woman should still get Pap smears, because I think it is a great way to detect if anything not well is going on down there. Of course, I'm a DES daughter and I get them every year, but I do recommend pap smears every year. What do you guys recommend?
I
Not every
recommend for
year.
high risk people to get it. For low risk people are in long-term monogamous relationships, the rate of cervical cancer in that age and older is virtually, nil. It can happen, but it's not very common.
David, Holly?
I don't recommend it for every year. I don't see many women really willing to do it, and the incidence is so low. Now, in a high risk population, which I don't see very much of, that, like David said, that could be a different story.
Funny, I had Anna Kabecka, who's a really great gynecologist from Dallas, speak to my pro group, and she recommended doing it yearly, every year. She said there were a number of cervical cancers that were missed. At least that was in her patient population. Holly, do you want to make a comment on that?
Certainly, I don't disagree with that. I think it's probably an overcall, perhaps, in just the regular population. I do love a pap smear every now and then just to look at the vaginal mucosa. I think it's a great marker. Dr. Rosensweet teaches at length about how it's a great marker for what do your hormone levels look like. It's kind of a rudimentary picture of, do you have enough hormones on board? Is there enough estrogen and such? Just looking at mucosal lining. So there's a lot of things that can be gained by the pap, I guess, even outside cancer screening, but I don't think it needs to be done every year. Infrequent.
Must be just my DES lenses. Okay. So, so the final question, because it leads us beautifully to one of the other reasons why we've gathered together in a community manner. I mean, these people that we have here tonight are extraordinary. They have moral fiber to beat the band. These are good people. And these are people who never stop learning the details of the science and asking. And as a consensus narrative, we are saying that hormones are safe for all humans, should be considered in all humans, but you have to treat the patient more than the laboratory, and that hormones are not drivers of nastiness. They're protectors. They're the armor against nastiness. So one of the final questions that I'm going to take here is, can breast cancer survivors with estrogen positive cancer, I had ER positive, PR positive, HER2 new positive, I had the whole shebang, and related treatment, have an estrogen patch after decades of not having any HRT. And these are the very things that we are going to be dealing with in everything breast cancer, how to keep it right. So I'm going to share my screen for a second. I'm going to share, and I'm going to go to view, view as in, why is it not doing that? I don't think you can see it yet. Why is it not going here?
We can see it, but it's
You
not
can't
in
see
your
it?
large.
Okay.
It's not large, but yeah.
I know, I just couldn't get it. So everything breast cancer, hormones for high-risk patients, getting it straight, keeping it safe with 14 top experts. It's going to be online, 20 hours of Category 1, the highest Category 1 CME on Friday, Saturday, and just it's on Friday, Saturday, and Sunday morning. And it's going to be CMEs for MDs, DOs, nurse practitioners, nurses, and PAs. And it's pending. Hey there, we have Zan on the phone here. Zan, it's pending for naturopaths. And we are launching the link active tonight. Is the link going to be in the chat, Sarah?
It is in the chat. It's been there a couple different times.
Okay, so the
we're
link will
good.
be in the chat. We do have an early bird special going on. There's never been a symposium like this before. And we have 14 of the top experts. Rebecca Glasser, who's done almost 25 years of exhaustive research on using testosterone to treat breast cancer. But one of the reasons is because it signals the second estrogen receptor, that's an anti-cancer receptor. We've got Dr. Siegfried, who is the initiator of the metabolic issue of cancer. We've got both of Dr. Brownstein's two daughters who are physicians and in practice with him, which is extraordinary. His family is just amazing, and his daughters are smart and fabulous, and they're specializing quite a bit in cancer. This is all going to be about the treatment of cancer, not the prevention, not to don't eat ultra processed foods. And we're going to have throughout the 2.5 days about 25 case histories of patients that had breast cancer, and this is what the providers gave, and this is how they're being tracked, and this is what's going on. This is going to also highlight dormant tumor cells, which are cells that can live in your bone marrow and nooks and crannies in your body, and they basically drive recurrence. You know, you go through chemo, you go through radiation, and then you go out and you cross your fingers and hope you never get cancer again. But some people have these dormant cancer stem cells that really are like a cloud over their head, making that much higher risk of getting cancer back. So we're going to be talking about identifying dormant tumor cells and trying to decrease their possibility in driving recurrence. This is everything about the treatment of breast cancer patients from incredible speakers. There's 14 speakers at this conference, and David knows how exhausting and stressful it was to pull all these high and people together. It's the first of its kind. We'll have this link, and we hope that you send this link around to a lot of your colleagues or your own providers so that we can get the message out that Mother Nature wouldn't make the very hormones that drive humanity be cancer causing. And there are lots of cancer patients who can experience the benefits of hormones, but they're done in specific ways at specific time and in different ways. So how do you do that as a provider? No one else has ever really tackled that in a conference like this before. So I hope that you will be excited to want to take part in this or help us get the word out. Is there anything that the three of you want to say after I've shared everything breast cancer? Didn't Sarah do a beautiful job with our branding of this? I think she did a great job. Thank you, Sarah and Karen. Anything that you want to say?
I think it's a wonderful thing for you to put this together. There are so many women who've had breast cancer and are terrified, are not doing well because they've lost all their hormones in one way or another, and they need those hormones. And the best information is those hormones serve every one of them. And I just think it's such a service to be able to antidote a fear that's even much bigger than the WHI ever was. And so good going. I'm honored to be a part of it.
Well, you know, I would really, and say this often, but I mean it from the bottom of my little chambers of my heart. I wouldn't be who I am today if I hadn't been on hormones all this time. And I was on them very low because everyone got me frightened. So I was on them with my toe in the water. And then when the 2019 reanalysis of the Women's Health Initiative came out, then I was like, oh, yeah, give it to me. And I really increased the dosage to the point where I knew I wasn't taking too much, but it was higher than what I'd been on before. And that's when my life took off like a gangbuster. So that in my 70s, pretty much most of the time, I mean, I have to deal with some health issues here and there, but pretty much I have a health level that not too many people get to enjoy in their later age. So I felt I had breast cancer. It was ER positive, PR positive, HER2 positive. And every time I'd go in and see my breast cancer surgeon yearly, because they're the best palpators, and I didn't want to get a mammogram every single year. So every year, my breast cancer surgeon would feel my breasts, and she'd look at me and she'd go, "You look better than any other breast cancer patient I have your age. You got to get off hormones." And I went to her for 25 years, and she looks 25 years older than me because she's so against hormones. So I felt like this was one of my missions in life, was to share this science-based information. Anything you want to say, David? Because you're a co-organizer with me in this.
Lindsay, you've been blazing the trails for this, and I'm happy to help out and to do this with you. I'm honored to do it with you, and I'm sure the four of us would say it's an honor to treat patients. It's certainly an honor to treat patients, and it's an honor to do this.
Love it. Holly, do you want any final words, my new growing dear bestie?
Well, I have to say, this is the most rewarding work that I've ever been a part of. I mean, the way you can change people's lives and improve their quality of life and prevent disease and give them their life back. I mean, Lindsay, you said it. So thank you for letting me be a part of this. I feel like I'm surrounded by it. You guys are the greatest. You're the pioneers. I'm just grateful to be here, and thank you for including me. But I think this is a great session, and like Dr. Brownstein said, thank you for continuing to lead the charge. It takes a lot of courage to kind of stand up against the dogma and the mantra that everyone's harping at us, but it is wrong, and you're doing right. So thank you for bettering lives. So.
Wow. And Dr. Rosensweet, you've been on this path with me. Isn't that funny how that all worked out? Wow. Wow, wow, wow.
With much joy and much fun and much pleasure. And so appreciate your deep, deep inquisitive mind. And let's figure all this out.
So we don't want you to miss out. We want you, when you're just making enough money. I know it's hard in inflationary times and you get older. Why not have incredible vitality, incredible capability to do whatever it is that you want to do? As crazy as it is, I still feel like I have a lot of my life in front of me. I don't feel like I'm at the end of my life. I don't have that verbiage and that world life viewpoint. And I think that's not the only thing that gives me that, but I think foundationally, it's been hormones. And if I had been any other woman who had breast cancer, ER positive, PR positive, HER2 positive, I would never have been able to have hormones, be on hormones. And I wouldn't be able to have the mentation and keep up the career to be able to offer this, which is really a big deal. Thank you all for being here tonight. Thank you so much for taking time after you were seeing patients today. Thank you, Karen and Sarah, for helping us pull this all off. I love all those hearts. That makes me feel great, and it matches my red. And blessings, everybody. We're here to help you be the best version of you could be without joining the darn army. Okay, blessings, everybody. Thank you all for being here tonight.